Hello and welcome back. We were talking about chapter 184 and demyelinating diseases. This is the makeup class for March 31st of 2021, Wednesday, and it is Cesar Chavez Day of Service. So back on our topic here. So other common early symptoms of multiple sclerosis or demyelinating diseases in general. Slight stiffness, unusual fatigability of a limb. This is not an uncommon thing for you to see as a chief complaint in your office, right? So they just feel stiff. Okay? And in our case study that we were looking at, she had issues with her left leg, minor gait disturbances, difficulty with bladder control. Okay? So neurogenic bladder, so frequency and urgency, and then needing to void or urinate without actually having a full bladder, and then a lack of ability to control it sometimes. Vertigo, very common. Mild affective disturbances, so think mood, okay? So mood. So all usually indicate some sort of scattered central nervous system involvement and could be subtle. Okay, so if there's an issue with your nervous system, your body knows, but it can't quite put its finger on it. And that can create not only mood disturbances, but anxiety, depression, all sorts of issues. Okay? Excess heat. So this is a weird sounding word, Ut-Hof's syndrome. Ut-Hof's syndrome, okay, or phenomenon. So hot weather, hot bath, fever, or hot tub. Anytime a person that has multiple sclerosis overheats, we want to be wary of this. Okay, so may temporarily exacerbate symptoms and signs, and that temporary exacerbation or relapse or flare, might be temporary, as in a couple weeks, maybe a month, maybe longer, okay, or maybe just a couple hours. So when we're telling our patient to do yoga, yoga is great for balance for all sorts of reasons. A lot of neuro rehab just looks a lot like yoga, right? So we tell our patients to go do yoga, but do air-conditioned yoga. Do not go to hot yoga if they have multiple sclerosis or a demyelinating disorder or any of the metabolic issues in the body as well. Okay? Mild cognitive impairment, so you might call this brain fog, okay? Brain fog, or just not thinking clearly. Again, affective disturbances including emotional lability, euphoria, most commonly depression are common. Depression may be reactive or partly due to the lesions. And a few patients will even have seizures. And this is straight out of the Merck. This is just cut and paste from the Merck. Cranial nerves, my favorite subject, and yours, hopefully, right? So unilateral asymmetric optic neuritis and bilateral INO or internuclear ophthalmoplegia are just so typical, just salient features of MS. If you have a patient that has optic neuritis or INO, we're checking for MS. Okay? They've already probably been diagnosed with MS. Central vision is affected more than peripheral. That's what the Merck says. That's not my experience, but that's okay. Optic neuritis, okay, so inflammation of the optic nerve causes loss of vision, okay, so scotomas that we saw, and we'll see again, to blindness. Okay, sometimes, as in our patient's example here, she just lost peripheral vision in one eye, okay, and it came back. Okay. Right, so abnormal visual field, swollen optic discs. Sometimes you could see that on your ophthalmoscope exam. Or a partial or complete afferent pupillary defect. Okay, is something going on with their pupils. Okay, INO or internuclear ophthalmoplegia in between the nuclei. Remember, so the nuclei being the cell bodies for the nerves. Okay, so think cranial nerves 3, 4, 6 when we think about eye movements. Okay. Results in if there's a lesion in the MLF, medial longitudinal fasciculus, connecting 3rd, 4th, and 6th nerve nuclei or cell bodies. Okay. During our horizontal gaze, adduction in of one eye is decreased with nystagmus of the other, or abducting, okay, looking away. Convergence is intact, In MS, INO is typically bilateral. Unilateral INO is often caused by an ischemic stroke. And these are just generalizations, okay? So when it comes to MS, pretty much anything is possible is what you want to know, okay? Same thing with stroke. Okay? It just depends on what structure is being affected. And then that will show us what that pathology looks like. Okay? Rapid small amplitude eye oscillations in straight ahead or primary gaze, or what we term pendular nystagmus, are uncommon but characteristic of MS. So if you see that, we're thinking MS. Okay. Vertigo is super common. Intermittent unilateral facial numbness or pain. Trigeminal neuralgia is super common complaint with your MS patients. Palsy, spasm can occur. Mild dysarthria. I posted a video of Selma Blair giving just a very brave and courageous interview while she's suffering with dysarthria from multiple sclerosis. If you want to check that out, you can see exactly what that looks and sounds like. Caused by bulbar weakness, cerebellar damage, disturbance to cortical control. Other cranial nerve deficits are unusual, but may occur secondary to brainstem injury. Again, it's really just about what structure is affected, and that's going to dictate function, and it could be anything. Little reminder here for you. So I have a lot of these slides in here just as resource for you, so you didn't have to look back through all of your notes from your different classes. So your 12 cranial nerves here for you, as you well know. And the nuclei. So this one might not be as familiar in your mind's eye, so I like to include this as well. So a little orientation here. So cerebellum right here, so fourth ventricle right here. We look for the circle, right? This little oval shape, we know that's the pons. So above it is going to be midbrain. We can see superior colliculus, inferior colliculus, and then we have our pons, and then we go below is going to be medulla, and then it turns into the cord. Okay. So check this out, right? So we know trigeminal here. So when you see mesencephalic, that just means midbrain nucleus. Okay, midbrain cell bodies of trigeminal nerve. That's all that part means. Okay, you can see it coming out here to the 3 branches, and then you can see the nuclei coming all the way down, and then they're just denoting this part as the spinal nucleus because this is going into the cervical spine. That's why an adjustment into the cervical spine will affect the trigeminal nerve, or may hopefully affect the trigeminal nerve because it's connected. See? It's great, right? You can see the little sensory nuclei here in the pons area. And then let's look. We could see Edinger-Westphal, that's associated with cranial nerve 3, right? Edinger-Westphal. So think pupillary control, right? This visceral ocular motor. And then we see nucleus of ocular motor nerve here. Okay? We memorize those in neuro for a reason, right? Because it's going to all the eye muscles except for lateral rectus and superior oblique. Remember, SO4, LR6, all others, or all over 3, including pupil. Okay, great. Here's the little nucleus of the trochlear nerve. It's small. It only is innervating one muscle. What muscle is that? Good, SO, right? SO4, superior oblique. Here's trigeminal motor. We can see more. Nucleus of abducens, 6. Okay. Lateral rectus coming out. Okay. So on and so forth. So you can kind of check this out. Okay. And what would happen if there was damage anywhere in here? Right? What would happen if there was damage? We know by definition, if we want to get it right on our boards, that MS affects the myelin sheath, but then we see all these resources saying that it can also affect the gray matter, which is traditionally the nuclei here, or the cell bodies. Okay? So as soon as we learn a rule in neuro, we break it, right? That's kind of how that goes. This is just a different view. So what you see here, right, is the superior colliculi, inferior colliculi, or the 4 we call corpora quadrigemina, remember. Okay? And then you can see trigeminal right here. And you can see that midbrain nuclei of trigeminal. So just a different viewpoint here for you. This is the fourth ventricle. So what's been cut away here, these are the cerebellar peduncles right here. And so what's been cut away is the cerebellum. Right here, cerebellum. A little view here for you. And I'm just going to skip through these right here. So you can go back and go through your cranial nerves if you need a review. So I'm just going to skip right on through. Okay, so ocular motor nerve, cranial nerve 3. You can check this out right here. Okay, so remember that we look at the nose for SO4, right, when we test it. Okay, when we test it. You remember this one here? And again, these are just to give you an idea of what would happen if anything along this line might have a lesion. Okay, so cranial nerve 3 damage, we'll see lazy eye, diplopia, double vision, ptosis. What's ptosis mean? Good, drooping. Okay, mydriasis. Okay, so dilated pupil with a D here. Okay, all ipsilateral. This is all happening on the same side. Trochlear, you remember that. What's going on here? So she's got this head tilt to deal with this. So maybe your patient's not going to have this to this extreme, right? So we know that the head is going to tilt lateral bend towards the strong side of the cerebellum. It could also be this, or a combination of both, right? Or just a subluxation, or the subluxation caused because of this. So many ways we can look at this, right? So ipsilateral, same side, eyeball drifts upward and slightly out. We see double vision. Patient tilts the head away from the affected side and tucks the chin in order to compensate, and they might not know they're doing it. Okay? And then they might just be complaining of neck pain or headaches because their neck is subluxated. Okay, cervicogenic headaches. Right here, okay, so we looked at this before. So PAG, what's the PAG do, right? That was the question here. So let's look. Okay? So we're looking. We see this is inferior colliculus. So remember, you hear something out of the ordinary, you turn and you look, right? That's inferior colliculus. So this is the level that we're at in the midbrain here. Right? You can see the cerebral aqueduct connecting the third and fourth ventricle. Okay. So here's the trochlear nucleus. Okay? Cell bodies for the trochlear nerve. Okay? And you can see that it's right here. Okay? Superior, inferior colliculi, cerebellar peduncles. And then over here, a real picture, you could see the trochlear nucleus, right? Not very clear cut. I mean, you could see it, but because we know it's here, right? But if we had to pick that out without a line there, that would have been hard to see the first time around, right? And then this periaqueductal gray, or PAG, okay? Periaqueductal gray. And the question I had for you last time was, what symptoms might someone have if the periaqueductal gray were damaged? Again, gray matter can get damaged, even though we don't want to answer that on our boards, right? It's white matter, it's myelin, right? Oligodendrocytes, specifically, because it's central nervous system. But if the periaqueductal gray is involved, I immediately think of serotonin. So I'm going to think of depression, mood disturbance, right? Anxiety, and all the things that serotonin does for us. So also pain suppression is key as well. Pain suppression. Okay? And that's the number one reason someone's going to come and visit us. Okay? Here's 5. Okay? A little refresher on cranial nerve 5. Face, pain, temp. Right? So trigeminal 5 is, we like to think of it kind of like spinal thalamic tract, but for the face. Touch, pain, temperature. It's huge. Also, muscles of mastication or chewing. So when our patient has Tmj dysfunction, why? Right? Why doesn't the body just set itself straight? It's a pre-programmed stress response, like this dog growling, gnashing his teeth, telling you that it's stressed and it wants space. Right? We're doing the same thing, usually one side or the other. Little refresher here. A little bit more here. So you can see it could be damaged anywhere along these lines, anywhere along the lines. You cut the cord on your extension cord anywhere along the lines, you're still going to have the same dysfunction, right? If you've plugged something into an extension cord and the cord gets cut in the first few feet or the last few or the middle, it doesn't matter. It just doesn't work, right? 6. Okay. You can see this here, so there we go. Remember these. Any damage along here, we're going to see issues with it. 7, facial, same thing. Vestibular cochlear, what if it happens at the vestibular aspect? Hearing, not usually affected by MS. Okay, but vestibular, yes, absolutely. But as you see, there's so many different structures responsible for balance, right? So it could be the vestibular nerve, it could be also the cerebellum usually, right? Or a combination of both, or any of the other systems at work here. Okay. Just going to skip through these here. You could see what the symptoms might manifest as. Okay, so she had tinnitus or ringing in the ears and some balance issues, right? Motor weakness. So back to the Merck. Okay, so motor weakness, super common. Okay, usually reflects cortical spinal tract. Okay, cortical spinal tract damage. So think of the deep tendon reflexes or the misses, right? So MRS, so muscles, okay? So myotomes, reflexes, and sensory or dermatomes, okay? So deep tendon reflexes usually increased. Babinski sign is not uncommon. Clonus present, spastic paraparesis, giving them a stiff, imbalanced gait, giving them balance issues again, right? In advanced cases, you're going to see patients in wheelchairs, bedbound. Okay? We need to help them. We need to remember this stuff. And if you don't want to specialize in this, please understand there are chiropractic neurologists that do. Okay, so they are not stuck in this wheelchair. In my mind, and in a lot of chironeuros' minds, they are not maximally medically improved just through medicine. Okay, so if they're still stuck with mobility issues or any issues, please send them out to a chiropractic neurologist. Please know that we work with this all the time. Okay, this is my specialty and near and dear to my heart here, because you see the most amazing recoveries I have seen in my life, and my experience as a chiropractor has come from working with MS patients. Okay. Painful flexor spasms, you know this, right? So our flexion protection is dictated by the red nucleus, remember, or rubrospinal tract. And on our boards, we want to talk about how it causes a flexion response in the upper extremities. But now we know it also can cause a flexion protection or just a protection response in the lower extremities as well. Okay? But upper for your boards. And who could forget Homer Simpson, right, with his red nucleus and his fetal position, right? Cerebral or cervical spinal cord lesions may result in hemiparesis, which sometimes is the presenting symptom. So we saw these little dots right here, little tiny dots. Okay, multiple sclerosis or sclerotic lesion, plaque, whatever they want to call it, in the cervical spine. So my question to you is this indicative of an upper or lower motor neuron lesion? All of this upper, see how it's increased. Okay, Babinski's is an upper motor neuron lesion sign, meaning that it's coming from that upper aspect. Here's a cool picture of that cortical spinal tract, right? Again, anywhere along these lines, we're going to see these symptoms, right? And it depends on where it's hit. Cortical spinal tract over here, okay? You can see the MLF, okay, right here, this little line. MLF, and the different nuclei as well. Spinal cord, back to the Merck. Involvement commonly causes bladder dysfunction, we know that. Constipation, erectile dysfunction, genital anesthesia, urine and fecal incontinence, and it could cause all sorts of things. Okay. We went through this, Charcot's triad, SIN, okay? Scanning speech, intention tremor, and nystagmus. Intention tremor is going to be just super associated with cerebellum. Okay? Ataxia. What else? Sensory paresthesias here, loss of sensation. Okay? Various painful sensory disturbances or burning or electrical shock-like pains. So the example over here in this picture is Lermite sign. So a quick flexion of the neck, tuck the chin to the chest, and the meninges are just like really stuck and tight in this scenario here. There's just some inflammation happening, and we'll see them get a shock-like sensation down the arms and the legs, or some variation of that. And that is a salient feature of MS. So if you're doing a range of motion for your patient and you come to cervical flexion and they get this weird shock-like pain, I'm sending out for an MRI just on that. Right? Just on that alone, because it's such a salient feature of it. Okay. Doesn't happen all the time though. So negative in your office right then and there doesn't actually mean anything. Okay. But a positive, big old red flag. Okay. Diagnosis, it's MRI. Okay. So many neuros will just diagnose it on MRI, and it's a diagnosis of exclusion. So you look for other things like Lyme's disease. Lyme's disease could be causing it. Remember, it's just scar tissue on the nervous system. Okay, so they'll look for other things, they'll exclude other things, and then come up with the diagnosis of MS if not finding anything else to call it. Okay, so they'll also do a lumbar puncture, okay, for cerebral spinal fluid, but not necessary. Not every neuro is going to do that, because why poke into something that's sacred, right, into your cerebral spinal fluid with a syringe to look to see if your nervous system is damaged? So if they already have a fragile nervous system, right, that's pretty invasive. That's about as invasive as it gets, right? I mean, brain surgery would be more invasive, but this is a pretty protected site. Okay? So I caution people on, is that lumbar puncture, is that evaluation of the cerebral spinal fluid really going to change your treatment plan? Okay? Is that going to change your treatment plan? What's the risk versus the reward? Okay? That's what we do as doctors, is we weigh those risks versus reward. Sometimes it's worth it, sometimes it's not. Okay? Okay, so you could read the rest of that. We've talked about that. So we talked about this. Okay, so checking those IgG levels, right, correlate with disease severity. So I have my patients do a food sensitivity test to see what foods they are eating that cause a spike in IgG. Okay, and you just never know. So when I did mine, mine spiked with chia seeds. Chia seeds are supposed to be a superfood, right? I'm not supposed to eat them because I create extra IgG to them. Go figure, right? Just weird random things. So you'll be hard pressed to find a patient or someone that doesn't have a reaction to some food or another, whether they're a normal nervous system or fragile. Okay. This is a cool site. If this is of interest to you, you can look at the slide share here of another presentation by this doctor about multiple sclerosis. I left it in here, put it in here because I thought this was really cool that we're able to test the metabolites now, okay, associated with it. So you could see the lesions here. Now, I don't know why this looks like a square. I don't know if they went over this to like, I don't know. I don't know what's going on there. This is somebody else's slideshow here that I thought was interesting. And then you can see the spikes of the different metabolites associated with this. Pretty cool stuff. So check that website out if this is of interest to you. Here's a couple more MRIs. See these white spots? Okay, white spots. That's the those are the lesions. Okay. Increased fluid, meaning that there's decreased structure. Okay, so the space is getting bigger. Atrophy of the brain. You can see all over the place that there's atrophy here. Okay, these are big old lesions here. So it depends on where that scar tissue is. Okay, it depends on what the structure being affected would be, and then therefore the function. Same here. These are the Dawson fingers. Okay. Cerebellum. Okay, so check out here, right? And then we kind of associate with this. So if we knocked out the dentate nucleus, dentate is associated with dexterity, right? So maybe they're dropping stuff. Okay, so maybe she's dropping stuff with her left hand and she's got a lesion on the left cerebellum. Okay, so remember, cerebellum is ipsilateral to the body, contralateral to the cerebral cortex. Okay, or right side cortex, left cerebellum, left body. Okay. I'll say that again and vice versa. Left cortex, right cerebellum, right body. And then you could see if different areas are affected, what symptoms they might have. There's some more. You can see these little plaques right here. Okay. What might happen there? And you can read these here, right? So we would look and see what structures are affected. This guy right here, large MS plaque in the 8th nerve, right? Okay. So we know that they're going to have balance issues, and so we need to reroute that balance system. Okay, challenge it and educate it in a different way. Good. Right. This guy here again. Okay. And then just kind of showing you, that's why we look at our structures so much. And then you can get into it some more if you like at this website here, if this is of interest to you. Again, just a little refresher. And then here's our deficit. So this is from cerebellum from our neuroscience class, NOLT. Okay, so follicular nodular lobe, if that's an issue, okay, if there's a lesion there, we might see these symptoms. Anterior, parts of vermis, posterior, medial parts, we might see these symptoms. Posterior and hemisphere here, we might see these symptoms. Okay, so look at their symptoms and then look at what those structures are and then what other structures help out with this and then strengthen that. Again, okay, midline dysfunction, gait, titubation or the moving of the body, nodding back and forth, spontaneous nystagmus, mood. Okay, remember there's a homunculus man in the cerebellum as well as the cerebrum. Okay. In the post and precentral gyri, remember there's that homunculus man. All right, Neuromyelitis Optica, we talked about this a little bit. It's called Devick's disease, so you could read that. Here's the picture of the visual evoked potentials here. There's some other tests. Again, IgG antibody specific for Neuromyelitis Optica, right? IgG. Prognosis. Okay, so Merck is probably going to have a different prognosis than I would for the patients. Okay, so it really is going to depend on the severity of the disease and the commitment the patient has to doing a complete lifestyle overhaul is usually what's required. Okay. Treatment, this is the med treatment here for you. So they just shut the immune system off. Okay, corticosteroids, immune modulators, which get rid of the immune system because they see it as an autoimmune disease, an overactive immune system. It's not overactive, it's just not properly modulating, right? So like when we train police or military, okay, so they are using a weapon to, shoot the bad guy, for a very simple example. Okay, and then you've seen those training videos where like the bad guy pops up, right? The little paper pop-ups, and then they have to distinguish between the bad guy and then like a family pops up, right? Or a baby carriage pops up, and they don't shoot that. Okay, so do we just take guns away from our military and our police force, right? Loaded question right now, but do we just take the gun away completely, right? Do we disarm the immune system completely, or do we train it so it's able to recognize the bad guy and the ones not to shoot? Same thing with our immune system and our autoimmune look on life, okay? Modern medicine shuts down the immune system. We look at it and say, what's going on? Let me support the immune system properly. How do we do that? Usually vitamin D, and then getting rid of offensive factors, okay? And we'll talk about those offensive factors more. But we always just bring it back to the 3 T's, right? As chiropractors, we look at all the complexities, but we bring it back to the simplicity of thoughts, traumas, toxins, okay? So get their thoughts right, okay? Easier said than done. Get rid of toxins, okay? Heal the trauma. So much easier said than done, but that's where we always come back to when we get a little overwhelmed, right? DMDs are disease-modifying drugs. I'm not going to get into these. This is the Merck, but you can look at it, and it's just overwhelming information about how do we shut the immune system off, okay? And it's a dangerous thing, in my opinion. Okay, here they are. You could read it. Symptom control. Okay, so other treatments. Okay, so these are all a bunch of different medical treatments here. Again, notice they're not even mentioning us, right? And this is what we do as, well, chironeuros, right? Down here, I put a highlight in here, so I made this little thing up. It worked really well. I told you guys about this, so it's a sin, right? To have MS is what Irene Gold will give you as the mnemonic: scanning speech, intention, tremor, nystagmus. And so what we do here when they have that neurogenic bladder hit, right, and they got to go and they got to go now. So on their way to the restroom, as they run to the restroom, have them say a tongue twister, right, because scanning speech, right? So we're going to exercise that. And then have them do their eye movements, okay, nystagmus, all of the eye muscle movements, right? And then have them running to the bathroom and then void, continue to do your eye movements and tongue twisters, right? And then slowly they can maybe undo that neurogenic bladder, maybe, right? So I've seen it work, haven't really seen it not work, but it doesn't mean it doesn't work, or you know what I mean. But it's nothing dangerous, right? It's not a new med. It doesn't cost anything. If it works, cool. If it doesn't work, right, keep trying. It might work later. Supportive care. Okay, so this is straight from the Merck. I'm really glad that they're mentioning vitamin D. Okay. So encouragement and reassurance helps. Okay, so thoughts, traumas, toxins, thoughts. Regular exercise. We want them going to like a physical therapist that specializes in MS. Okay. And then once they're healthy, strong, equalized, feeling great, then they can go to like a general, like basic yoga class. That would be nice, right? Not hot yoga. Vitamin D, okay, 800 to 1,000 units daily. That's tricky, right? So we know, don't guess, test, right? That's what we say all the time. Don't guess, test. How do we test? What if they don't have access to insurance? What if it's expensive? What if you're not in network with their insurance or they won't let you get the test? This is $50. They do it at home or in your office, depending on where you are working, right? So some states you can puncture the skin, some states you cannot, okay? So they can do a self-test, send it off to Everlywell, $50, you know your number, you don't have to guess, and then you prescribe vitamin D based on what their number was. Right? So personally, myself, I keep mine. So we know that optimal levels for your immune and nervous system are between 65 and 95. And I take 50,000 IUs once a week. Okay? And I'll show you that in a little bit where I get that from. And that keeps mine at about 65. Okay? Plus, the sunshine and the food and all the other things that I do. So high levels. It seems like a lot, right? But if you were to sit out in the sunshine in shorts and a tank top on a nice day, you'd get, in about a half hour's time, you would get about a 40,000 IU hit. Okay, hands and face, not enough. You need like more skin exposed. Okay. Here, this is where we were going. So remember in the beginning when I told you, when we just read the Merck's introduction to demyelinating diseases, and that it could happen post-viral infection or post-vaccination. And then here it's like vaccination does not appear to increase the risk of exacerbations. So yeah, it's exacerbation versus cause, but anything that causes it can cause an exacerbation, remember. Okay? So any insult and injury, this is an inconsistency if you ask me. Okay? So different neuros out there are going to have different opinions on whether MS patients are special populations that require an exemption from a vaccine or not. I just know that conversation's out there. Debilitated patients require measures to prevent pressure ulcers, UTIs, intermittent urinary self-cath. Hopefully we're going to not see them progress to this. Again, this is their treatment. They're just going to shut the immune system off. Here's the criteria from the Merck. Okay, so it needs to be distinguished from the following. So CIS, or clinically isolated syndrome, consists of only a single clinical manifestation typical of MS. So think of it, instead of as the M, multiple, right? Just kind of think of it as like one, okay? Radiologically isolated syndrome, MRI findings typical of MS that are incidentally noted in patients but have no clinical manifestations. Okay? Seems like we are just really splitting hairs here, right? Because remember our remitting and relapsing and what's causing an exacerbation, what causes it to go into remission. MS can be distinguished because diagnosis of MS requires evidence of central nervous system lesions that are separated in both time and space, so location. For example, any of the following can indicate separation in time. A history of exacerbations and remissions, MRI that shows simultaneous enhancing and non-enhancing lesions, even after patients are asymptomatic, so that's when they add in the contrast or the GAD. Okay. A new lesion on a subsequent MRI in patients with a previous lesion. Separation in space can be established by finding lesions following central nervous system area typically affected by MS. So periventricular, around the ventricles. Cortical, juxtacortical, white matter next to the cortex. Infratentorial, so remember that's going to be the fascia, okay? Fascia at the cerebellum. So underneath there would be infra, or supra would be above it. Spinal cord and optic nerve. So remember, optic neuritis is a salient feature of MS. It gets complex, so every once in a while we need to take a little break and remember, okay, so there just could be damage anywhere along the line. If it's in the central nervous system, that is indicative of multiple sclerosis. Okay. So we'll see weird symptoms, remember, okay, because pain and temperature cross at a different level than the main pathway for touch. One-sided damage affecting these two pathways could diminish touch on same side and pain and touch on the other side. How weird, right? So that's why we think, wow, this is a weird symptom. MS is going to pop into your differential. Again, anywhere along the line in the central nervous system. And then they throw in that caveat of it could actually just affect the nuclei as well, right? So, but think about this, right? What if it's only affecting right here, or here, or here, or here? Remember how small the spinal cord is, though, okay? Super small. So think about it as like the width of like your thumb. Look down at your thumb, the width there, that's like the width of your cord if you haven't seen it in lab yet. And then all the functions, right? So look at the structure that's damaged. We know the function. Okay. You've seen these before. I just want to remind you, if it happens anywhere along here, we see all of these issues could be at risk. Okay, here's your tracks again. Anywhere in the central nervous system could cause an issue. Same. Homunculus man, right? So what if there's a lesion here at the foot in the sensory aspect? Okay, post-central gyrus. Then they would have sensory issues at the foot that have nothing to actually do with the physical foot, right? But it's the brain's interpretation. Same thing with motor, okay? And that's this right here, okay? Anything is fair game for MS. Okay, you guys know this, vibration sense, you guys know this. I just put it in here for reference sake here for you, so you get the idea. Anywhere along these lines. Balance, vestibulospinal. Okay. Anywhere along these lines. There's our good old Homer Simpson, which might be how you're feeling right now. Okay. So just go on back into your anatomy. If you know anatomy, right, you know what these different structures, what their functions are, you can help this patient. Okay, so what do we do, right? So what do we do with our patient? Okay, so you know how to do a SOAP for the subjective now, the history of present illness, or the HPI. So that's our MOP Corsta, okay? So, or our LMOP Corsta. Okay? We do an orthoneuro exam, of which you will learn. Maybe, right? So we're like, hey, we think this is MS. Send them out for an MRI. Maybe they don't want to pay, the insurance might not want to pay for a chiropractor's recommendation of an MRI, so you might need to co-manage with their primary care physician or a neurologist. It's usually quicker and easier for them to get into their PCP MD than a neurologist. Neurology appointments can take a while, so just understand that part of the system. Perhaps refer out to a chiro neuro if you're not comfortable treating. Okay, we treat this. Chiro neuros treat this, right? Or co-manage, or would be a good thing to refer out to. Plan. You do your neuro rehab that you're learning here based on your specific findings of your exam and what the MRI says. Okay. So currently there's no cure for MS. Okay. So it's really hard to create a treatment plan of saying, hey, you're going to be better in 2 weeks. Hey, you're going to be better in 2 months, right? There's no cure. So nobody really knows how quickly or how slowly or what exact recovery you're going to be able to achieve with them. Okay? But many people have found relief and are thriving doing natural therapies, okay, which include traditional chiropractic and especially chiro neuro. Okay, so we need to understand brain anatomy, our rule of 4s, cranial nerves, of which you are experts at by now, eye movements, the MLF and the tracts, okay, so medial longitudinal fasciculus, you know that, and then our cranial nerve exercises, of which you've done those exercises last term or the term before whenever you took neuroscience with me. You did a video of that. Our vestibular ocular reflex exercises, which kind of look like the cranial nerve exercises there, right? And our cross crawls. Okay, so cross crawl patterning, how did baby gain balance in the first place? They crawled, right? And if they didn't crawl before they walked, we have to do cross crawls with them and kind of wire the brain that way, or they might have problems later on in life. Little reminder here for you to check out the SOAP note that is on Canvas. And we had a subjective script, right? So the history of present illness, we went through that. So take a look at that, and that would be a typical multiple sclerosis patient's presentation for when they come into your office. So maybe you can kind of catch that early for them, right? On here, I put the objective. Okay, so for our example patient, this is not a real patient. Okay, I found the picture on the left online. But on month 4, MRI demonstrates new 2-centimeter lesion on the left cerebellar hemisphere and a high signal on flare and a speckled pattern of contrast enhancement post-GAD image. So GAD is the contrast, that's the enhancement. So they do an MRI without contrast first, and then with contrast to see if something kind of lights up more. Okay, it tells you if it's active or not. Okay, so this being the goal for this one was just that you saw the picture, right? And this is quite obvious that it's in the left cerebellar hemisphere. Remember, the rights and lefts are switched here on this image. And then the idea would be, what would happen? Okay, so she was having left-sided issues, right? So her left leg was having problems. So remember that the cerebellum coordinates with the same side of the body, but the opposite side of the cerebral cortex. Okay, so in our example, this might be what her MRI looks like. And then just showing you here different things that might be affected. So we do cerebellar testing. Okay, so we'll do some cerebellar testing. We'll look at gaits, heel to toe walk, like walking on a tightrope. Okay, heel to toe. Single leg stance, as we're demonstrating here in Yoga Club. And heel to shin is an exam. Romberg's test, rebound test, pass pointing, pinky to nose. I'll remind you at the end to check out the cerebellum lab that you watched in Neuroscience Lab that shows all of these beautifully. This is another reminder that you saw already in neuroscience, but cerebellar lesions and cerebellar symptoms here. Assynergy, ataxia, decreased muscle tone, intention tremor. Always remember that. So we'll see it with our patients, and it's also a really good boards question and a good final exam question. So it really hits the trifecta, right, of boards, clinical relevance, and class. Okay? Rebound, he's exhibiting rebound phenomenon here. Lack of coordination, uncoordinated sequence of movement, okay? Truncal ataxia, maybe they can't sit upright. So you can read the rest of this, so on and so forth. But what you're going to notice is, that's important right here, you're going to notice that your patient is going to be standing with a wider stance. Okay, so check out your balance. When you stand with a wider stance, your balance is better, right? If you bring your feet all the way closer together, your balance, it's easier to push you over. Think about sports, right? They set up with a wider stance, so it's harder to push you over. Okay? So when you're doing your balance training, keep that in mind, right? So you'll do it in the beginning with their legs a little bit further spread apart so they get the idea of it. And then as you work to increase and advance the balance, bring their legs closer and closer together until their feet are touching. Okay? It's going to be a more advanced move. Lateral dysfunction of the cerebellum, and you'll see these symptoms with lateral structural dysfunction. Okay, so a jerky, irregular movements, broad-based gait again, hypotonia, dysarthria, dysmetria, dysdiadochokinesis, or DDK for short, and that's that rapid back and forth movement. Remember, you'll see tremor, again, impaired check and rebound, impaired spatial cognition, and affective or mood disturbances. This is my sheet that I use. Okay, so my exam form here, kind of keep track of these different tests here. Okay, so a little side note on the side there, stimulate the weak cerebellum side and the contralateral cortex side first, strengthen that first, then equal therapies once it's balanced as maintenance care. Okay, so here you would look at head tilt, Romberg, single leg stance, gait, watch them walk, heel walk, toe walk. Heel walk is going to be L5, remember, and toe walk is going to be S1. I just throw that in there right then and there because it's easy to do and makes sense to put it there. And then heel to shin while they're sitting. And then you can mark that it's normal, or you could mark that the right is weak or the left is weak. Or if you want to put strong there as well, you could. Okay, so make it your own. You could also put normal and then right weak. You could put both. Okay, so it could be normal technically, but you'll notice a slight difference. Okay. Eyes, so fixation instability, eye movement, so that cardinal field of gaze that you'll learn in orthoneuro. Convergence and divergence, we've gone through that. Flashlight or light reaction, pen light reaction. OPKs, optokinetics. Saccades, anti-saccades, pinky to nose, pass pointing, rebound, drift, and then your cranial nerves, which would take up a whole lot more space than that and have its own exam forms, right? So you can do these exams and then kind of check off and see which side is weak. Okay. So what are we doing here? So functional neuro exam, so cerebellum cortex test and localize the site of weakness. Okay, so watching that video is important here. So you guys watched that a week or two ago, depending on what day you're watching this. Stimulate, again, weak side, strengthen that first, okay, and then equal it up. One of the things to note is the head tilts towards the strong cerebellar side. We sway towards the weak side. Okay, so like in a Romberg's test or in a single leg stance. One of the notes here, it would be that if you want to do some cortical stimulation therapy, you do assent to one side. So if you want to stimulate the right side, so let's say her left cerebellum is weak, you want to stimulate the right cerebral cortex, because that correlates, it's contralateral to the left cerebellum. So you would put assent under one side. So close the left nostril, put in assent under the right nostril, and then do your therapy. Acupuncture or vibration to the weak cerebellar side. So this, if it's the left side, do some vibration therapy onto the left leg. Okay. I like to go at acupuncture points. So even if you're not needling into those points, we can go into some of the acupuncture points. So personally, I choose liver 3, spleen 6, stomach 36, these points along the lower extremity. Okay, and then the upper extremity, I would pick points like LI4, lung 6 or 7, LI11. Those are great points to stimulate on the extremities. If you don't know what I'm talking about, that's okay. We can look over a chart of those at another time. Great. So acupuncture or vibration, you can just put a massager into those areas, or grab a tuning fork, hit the tuning fork, and vibration into those areas. So like if you're putting vibration into that, what part of the spinal cord, what tracts of the spinal cord are you stimulating? Yeah, dorsal columns. If it's the lower extremity, it's what? Good, fasciculus gracilis. Upper extremity would be fasciculus cuneatus. You got it. Good job. Pulse ox. That's the pulse ox over there. So don't push them past their sympathetic or metabolic rate. So you put the pulse ox on them, and you want to keep their pulse and their oxygen pretty steady. Okay, so you technically like 95 is normal, but if they start off at 98, 99 oxygen sat, and they start dropping to like 97, 96, 95, I'd stop right there. So don't wait for it to go lower, right? Just stop right there, give them a break, give them something to focus on, to chill out, relax, give them some water, and then you can go again depending on where you're at in the therapy. Okay? Or maybe you stop for the day. Okay? That's where you use your discretion. And pulse rate as well. You don't want that pulse rate going up either. Okay, so the heart rate going up is telling you there's something sympathetic going on, and we've pushed past that sympathetic, that autonomic range, that metabolic rate that we want to kind of keep. Okay. So really nice biofeedback. Those pulse ox, they're pretty cheap in comparison to a lot of the other biofeedbacks out there. So really easy, and it's part of your vitals, right? You already have that to do your vitals. So localize to the cerebellum and cerebrum. Again, you watched that video, hopefully, so you can watch that again until you get it, right? Always bringing it back. We're chiropractors, right? So we bring it back to the 3 T's that Palmer talked about when he first started teaching chiropractic. So the 3 T's: thoughts, traumas, toxins. I also like the 5 essentials. They kind of bring it up a notch. So they go off of the 3 T's that we've already talked about, but there's a Max Living group here calling out the 5 essentials. Okay, so chiropractic, nutrition, mindset, oxygen and exercise, and minimizing toxins. And I put the link there if you want a little bit more information on that. But it's basically the 3 T's taken a little bit further and a little bit easier to give patient education on. So we want to prep our patient for a neuro reset. Okay? So we want to prep them for proper neuroplasticity. So as we talked about before, right, we need to get them off of NSAIDs. We know why now, right, because of its inhibition of VEGF, and we need VEGF to help repair the nerves, right? So even though she's in pain, she's taking these NSAIDs for pain relief. We need to fix that, right? We're not going to get good neuroplasticity while on this. We still do this. If they can't get off of the NSAID, we don't say, oh, well, can't do it. No, we still do it. We just have to manage their expectations then and tell them it's a higher degree of difficulty and explain why. Okay. The blood work that I like to do. So the CWP is called a comprehensive wellness profile, and that's at directlabs.com. I've mentioned that before, and I've mentioned it in this presentation as well. You can order it not on directlabs.com, but you can see what that looks like there. Okay. And hemoglobin A1c, going to tell you what their blood sugar has been over the past 3 months. Tells you a good level of inflammation, okay, how much sugar they've been consuming, because sugar is super inflammatory. HSCRP, or a high sensitivity C-reactive protein, same concept. We're looking for inflammation here. Vitamin D, remember we want to see it between 65 and 95. With our MS patients, this is non-negotiable. If we're going to help them, they need good vitamin D levels. I like to do a food sensitivity test, so I've already shown you why, because of the IgG component. So we want to lower IgG, right? And some foods, for whatever reason, will spike IgG, and we don't guess, we test. Okay. All right, that's just me, so don't worry about that one. Check with NNCC, so that's my natural neurology. Don't worry about that. That's specific to me. And get patient off NSAIDs because it's inhibiting myelin repair and formation. Supplements that I like. So I personally take and recommend and used to sell in my office orthomolecular, and they have a multi-called alpha base. You could use whatever you like. Just make sure that you research it and make sure it's a high quality supplement. This is just the one that I decided to do. There's one with and without iron, and you base that off of their blood work. Okay. Methylated B vitamins are extremely important, so you add them in until remission is achieved, and then the multi has enough methylated B vitamins once they're kind of stabilized. Vitamin D, again, get them to 65 to 95. Test, see where they're at, and then prescribe your vitamin D accordingly on how low they are or if they are just maintenance. Calm magnesium sleep formula. You'll be hard-pressed to find an MS patient that sleeps well, deep, and restful and restorative. I really like collagen with MCT for repairing so many different things in the body. I like all my patients to be on something like that. Green juice, of course, for repairing tissue. A probiotic because your gut-brain connection is extremely important. And the Perismart or the Candida Cleanse, that is going to help balance the flora of the gut. So you want to kill off the bad guys, as we say, and then repopulate with the good guys with things like probiotics or fermented foods. Water. Talk to them about water. You'll be surprised how many patients in general are not drinking enough water. You know the equation is your body weight divided by 2. That's how many ounces of water you need in a day. So make sure that you are encouraging that. Dehist or Sinotrol is a blend from orthomolecular. It's a really great antihistamine, anti-inflammatory combo. Pick whatever company that you like and find something that works. Okay. Boswellia is frankincense. It's a really great anti-inflammatory as well. Those are common in natural anti-inflammatory mixes. I'm a huge fan of Chirithin Cleanse. So you can look up Chirithin. It's a really good weight loss program that you could sell through your office. It's doctor supervised. It's only prescribed and sold to chiropractors. So it's a nice little reset for the patient to return to healthy eating. Reduce toxins, that's one of our 3 T's. You want to encourage them. When you took physiology, we went through this in one of the labs on the toxins in soaps, lotions, makeup, fragrance, candles, things like that. Any of the hormone disruptors, you want to knock those out because there's a hormonal component to multiple sclerosis. And then Epsom and baking salt baths, but watch out for that Uthoff reaction. Remember, not too hot. Okay, but Epsom salt and baking soda baths are really nice for anybody really that's having any musculoskeletal issues or just after an adjustment and they haven't been used to an adjustment or a workout lately. So hopefully it helps them not get so sore. Here's the vitamin D I like. You could check it out if you like or not. This one here at the bottom, orthomolecular, that's going to be the wholesale that I recommend that you guys check out all the wholesales for the different brands for you. Maybe start to get an account. Okay, and then I just put mine in here so you can kind of see how I have it listed on my website. Okay. You want to get it up quickly. I use this one. I personally use 50,000 once a week with a healthy fat for absorption. Remember, A, D, E, and K are fat soluble. So you're going to need a fat in order to properly absorb this vitamin. Always, we are chiropractors. We adjust the subluxations. Consider the sympathetic reaction and the cause of it. So go from head to toe, right? I actually go from toe to head, right? I go from the bottom up. You want to adjust the extremity. So on this patient, she has left cerebellar issues. I want to stimulate the left side. I want to overstimulate the left side, okay? I'm going to adjust or just motion palpate the talus, the toes, the foot, the knee, the hip, okay, all the way up the arm as well. So fingers, wrist, elbow, shoulder. I'm going to really get some good mechano-proprioception into that left side. And I'm going to leave the right side alone unless there's an injury that they're dealing with. Okay. Things to consider. So what tracts and structures are you stimulating? If you add in vibration to lower extremity, we went through that. Temperature changes to an upper extremity. What happens if you have them with their eyes open or eyes closed? Okay, what's going on there? Scent in one nostril, earbud in one ear to stimulate just the one side. Have them do their exercises with one eye covered, right? Think about that whole visual pathway. Vibration sense, plus one eye, one ear, one nostril. These are more advanced. Don't start a patient like this, okay? And keep a pulse ox on them so you can see when they start to get overwhelmed, okay? And then back off, go slow. Slow, steady, gentle is the name of the game here with our MS patients. Okay. So I found this paper. I thought it was kind of cool. A home balance exercise program improves walking in people with cerebellar ataxia. Okay, so you can read this paper if you like, but just the basics here. Physical therapy intervention is a primary treatment for gait ataxia. So they don't really have a lot of papers out there that are like chiropractic neuro rehab is helpful for MS. So we have to extrapolate. We have to see what's out there and then take that little leap of faith. That's what evidence-based is. So it's not only doing what there's exact evidence for, but it's basing your next step off of the evidence base that you have. Okay, so this is the base, and then we take that next step because we're physicians and we want to help our patient, and it might not be cured yet, and there might not be PubMed papers out there on the exact recipe on how to do that, but we can base it off of the evidence. Okay. So physical therapy intervention is primary treatment for gait ataxia and imbalance in individuals with cerebellar damage. Our aim was to determine if a home balance exercise program is feasible for improving locomotor and balance abilities in these individuals. And then they give you a really nice list of what they did. So you can make up your own if that's your specialty. Right, so I'm also a yoga teacher, so I do my own routine with my patients and for myself. And you could use this for sports. You don't have to just use this for MS, right? So you could just use this to keep your brain balanced. All of us are going to have a weak side and a strong side. It's just how subtle is it, right? And just in general, our elderly population, this is going to be one of their main concerns. About half of our population is going to be over the age of 50, and one of our main concerns is balance. So you can really bring this into any demographic, right? So you can see the seated and stable surface part here. Okay, so your patient that's in a wheelchair maybe. Seated dynamic surface, right? So like sitting on a ball or a balance board, tipping board, yoga disc. Standing, stable surface, progressing to a foam surface, okay? And then stepping and stooping. Okay? I like balance boards. You can make your own balance board. It can be cheap and easy, or you could get real fancy. Anything that's just going to kind of challenge their balance. Okay, so you can kind of go through these exercises here. Do it on yourself. See how it feels. Okay, start really stable. And kind of work up and see how it feels. It's going to be beneficial for anyone and everyone, right? As long as you find like your balance challenge. So mine again, okay, so I do my neuro exam. I include that BFAF that I've shared with you before. There's that PDF that's fillable, and then you just plug right into the form that we worked out before, and then the answer key. Just go off the answer key and prescribe them the neuro rehab. You could do it in your office, or you could have at home exercises, or you could get your CA or a physical therapist assistant or your front desk person multitasking as a lot of us do in the beginning, right? And have them run through some of these exercises with them, either doctor supervised or unsupervised. Okay? Blood work, went through that. There's the direct labs link. Diet is extremely important with MS, okay? Extremely important. I go for the deflame diet, anti-inflammatory diet. There's OMS, there's WALS, there's all sorts of different diets out there for MS. You could check those out if you like. Here's one here, foods to avoid if you have MS. It's basic stuff like no gluten, no dairy, no inflammatory foods, no junk food. Okay, so super healthy. You want to repair the nervous system, it takes work. Okay, and again, our food sensitivity, an MRI. Have them bring in the images. Read the actual images of the MRI and see if you can't determine the specific structures that are compromised in the brain and the cord. So maybe it's all over and you can't get that specific, and that's okay. We start off broad based therapies. But maybe there's just a couple lesions in a couple of very distinct places, and you could be even more specific with your care. Right? That's what we're about in chiropractic. Very specific adjustments, very specific neuro rehab. Okay? Massage, acu, chiropractic. I don't like to go alone on just chiropractic with patients like this. I like a multi-level approach. Okay? Massage, acupuncture, chiropractic adjustment, yoga, neuro rehab, everything. And the kitchen sink if I had one, right? Neuroacupuncture, specific to the deficits of neuro rehab exercises, including neuro-organizational technique. Now, we're not getting into these because it would take a whole, another year of courses to kind of understand these things. I just want you to know there's more to the story and more to be done. Okay, there's always more. And if your patient isn't responding, refer out to a chironeuro. Please refer out to a chironeuro. Okay, so there's so many people thriving under natural methods here. Of course, they need to also, you need to refer out to a neuro MD for an opinion, okay, to do your due diligence. But please note that there's more to the story than just meds. So here is the link to the basics from US News talking about those basic 5 foods to avoid that we just went through. There's also WALS, ohms, here's the words for it, so you can look those up and help people with it. Or I just subscribe to the Deflame concept. So you can look at deflame.com, look at all of the research there. And it's basically just anti-inflammatory paleo. That's what I use for myself. Just as, normal health, and what I recommend to every patient and every person, whether there's neurological issues or not, but especially if there are neurological issues, especially multiple sclerosis patients. Okay, so good for everybody, including neuro patients. So our balance training. Okay, so what do we do with specific patients? How are we going to train them? We go through that sheet, that exam sheet that I showed you, and I'll post a separate video specifically for this. Okay, so see this video more as lecture, okay, instructional, and then I'll show you the actual movements in another exercise video for you. So balance training, one of the things we want to think about is cerebellum, crossing over the body, and figure 8s, or that infinity symbol, super powerful for cerebellum. And I'll show you some of the crossovers for the body. So some of your patients that are in a wheelchair or bedbound, they're not going to be able to do that eagle pose over to the right, or where things are. So you could really have this same position while they're seated in a chair and just not cross over so much. So just crossing the right leg over the left, or crossing over the right arm over the left, and then training. Wiggle your right thumb, wiggle your left big toe, and have these in the line of sight. So again, we'll do this in another video so you can see what that looks like. Or you could just have them face up on a massage table like this and have them comfortable and do similar activities. So for our movement video, here is a list of supplies. So you don't actually need to get any of these. However, if you do have them, grab them for the video. They might be helpful. Again, you absolutely do not have to get these, okay? But if you have a yoga mat, or just really a space to exercise, okay? So kind of clear out a little bit of space for yourself. Maybe an exercise ball, something that you can sit on and balance on, or a balance board, or a yoga disc. If you have resistance bands, that would be great. If you have a yoga block, that would be great, or just something to pick up, really, okay, or prop yourself up with. And a strap. This is pretty easy to modify, so a yoga strap, a dog leash, scarf, something like that. So grab those things if you have them. If you don't, absolutely no problem with that. Just give yourself a little space to exercise, okay? And I will see you at the next video.